please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
My computer is having a bit of a psychiatric issue. So I'm on Kevin's laptop.
It's a good thing to have Kevin. I say this all the time.
Every day.
Right.
Yes.
Can we get t-shirts?
That say,
Thank goodness for Kevin.
thank you for Kevin. And Kevin is sitting here saying, no, I'm invisible.
Yeah, no.
It's the only way I get away with it is I only say thank you to him once a seminar at the very end. And I only torture him once.
Right.
Hawaii was so amazing.
Of course it was.
And then
amazing. How can it ever not be amazing?
it was so cool. I mean, the weather was weird, like raining up in the mountains and hot and sunny down at the beach.
Right.
Yay, you're back. Hi, Leaf. But the master class, she's an acupuncturist, right?
Which one?
Yeah, from Belgium.
Oh, I wasn't in the room, so I didn't hear all the people.
Well, you've got the list, I hope, because I have to send out the photograph. Tell me you have an email
I don't
list.
remember who was what.
Anyway, there was an acupuncturist from Belgium. There were 2 naturopaths from Poland. There was an MD and a PT from Taiwan. 2 people from Australia.
Wow.
Yeah, I mean, it was like, I understand Australia and Taiwan kind of because but Poland?
That's a big trip.
Belgium?
Big trip.
It was really fun. We had a good time.
An amazing, I don't want to say quote, but I guess theme from
Yes.
class, which is
We started out with a case report, and the patient described this horrible injury where this 220-pound man who was holding a 50-pound solid core door fell from about a height of 3 feet and landed on her while she was on her side.
okay.
And she said, I have been a mess all over ever since then. And it was like it happened a month ago. And I said, when did this happen? She said 8 years ago. So we started with that. And I said, okay, to the class. And she volunteered. So it was okay to talk about it. What does that tell you? That it happened 8 years ago. Yes, Derek, ouch. That it happened 8 years ago. And she talks about it like this.
Mm-hmm.
And they all, like, everybody's afraid to answer. And it's like, no, you know this.
Yeah.
Centrally sensitized. So you already know you need to run concussion in Vegas and 40 and 89. Then what happened? I hurt all over. Well, pick the place that's the worst. And she's pointed to her low back. And I said, when does it hurt? Well, it hurts when I stand, hurts when I sit, hurts when I walk. And then I asked her, does it hurt when you roll over in bed? And she said, oh, for the first 3 to 6 months, I couldn't roll over in bed. So what is, turning to the class, what does that tell you to look for?
Right.
SI joint.
Yeah.
Can't sit, can't stand, can't roll over in bed. Now it's 8 years, so it's not constant. But she said, it feels like my pelvis sort of slips. And she said, I have this terrible pain in my thumb. Said to the class, what does the pain in your thumb say? C6. What does that say? Look at her neck. Mm-hmm. And then there was something else she said. And I said, wait a minute. When he fell on you and you were on your side, did it hit your head? Oh, yeah. So I'm going to put up this questionnaire, and I just want you to tell me what number. So I put up the brain injury visual system symptom questionnaire, and I had somebody do the math, and her score was 62 over 18. I said, so you have a vestibular injury, and this is why you feel like this. She said, yeah, I don't know who I am. I said, well, that makes sense. It does? Oh, yeah, because the prime directive is, where am I in space?
Right.
And you don't have a where am I in space, because that ear is busticated. So the point is, the quote that I sent you was, by the time you finish the history, you should know what you're going to do for a physical exam.
Yeah.
And so we checked her SI joints. Both of them were painful. L5S1 facet, that was painful. Vestibular exam, she's totally flunked. Sensory, I think I forgot to do. That was the thing.
It happens, especially when you're live teaching a class.
Yeah. So, but we knew to treat disc repair on a custom care, and we treated concussion and vagus minus 94 because she was obviously a vestibular patient. And we added 40 and 44 to the neck pain protocol. So quiet the vestibular system, 40 and 44. And that made her neck muscles relax. And we treated her low back and SI joints with one machine, with 124 and 77, just to, and 124 and 100,
Yeah.
to just repair the SI joints, lumbar facets, repair the disc, and then supine cervical practicum. And at the end of it, her thumbs didn't hurt anymore. So just treating the disc was enough to take care of C6.
I just had a quick thought before it goes away. So treating 40 and 44, 40 on A, 44 on B, has been magical for me with a lot of my vestibular athletes. Do you think inserting that before 94 and 94 in the concussion could help the yucky feeling from 94 and 94?
I just put in 40 and 94 and 40 and 44, but
Yeah.
the other place that 40 and 44 belongs is the neck pain protocol.
Right.
And then the other thing that I ran into on myself, because I had a vestibular crisis when I was in Austria, was 124,
Yeah.
torn and broken.
Yeah.
And so it was like a 90-minute protocol I ran, and that worked. But we just put in 40 and 44 for maybe 8 minutes, 10 minutes.
Yeah, I'm just wondering, like I said, we typically take that out 94, 94 but I'm wondering if instead of taking it out, because I do think there's validity in running 94 and 94, if you could do something before that to mitigate any kind of unease.
My computer's back. Hold on. Hold that thought.
The echo is almost like the Lord Carol speaking to us. One of my favorite FSM bloopers is when Kevin and I were on and we were like, it's the Kim and Kevin show. It's just like two kids messing around with mom's computer.
I mentioned that Mercury's record.
Oh, I don't know much about it, but all my electricity exploded yesterday in the house and we had an electrician here for 12 hours. So I'll blame it on that.
Yeah.
While you guys figure out the audios, I have so many questions today. When you just have a questionable set of time, like why does this work? For me, I always go back to the absolute basics. And I'm just like, this is not new. Why don't I appreciate it or understand it? Or why haven't I used it? Or do you know what I mean? Do you ever have those moments?
Oh, yeah.
I'm going to talk.
You talk.
One of my favorite frequency. Well, maybe we can edit this somehow. But what I wanted to ask you about before we go back to your patient, or maybe we should let you finish with your patient from the advanced. I don't know.
Just knowing that she had a vestibular injury, what to do about it, meclizine, prism glasses, and we ran 40 and 44, concussion in Vegas. She got back in her body, stood up, had no low back pain, had no arm pain, had no body pain when we ran 40 and 89, and it was done. That was on first day. By Friday, she was still fine. And there was somebody on the second case report that we did. It's exactly the same thing. By the time you finish the history, you should know what the physical exam. I do a focused exam. There's no need to do a central nervous system exam when the patient's complaint is scar tissue from multiple fractures in his foot, right? You just do sensation, check mobility in his foot, check the stability, and then take apart the scar tissue.
Right.
So, yeah. And there was a third case report, but it was all three cases that we did in the class were the same.
Yeah.
So that was the theme. And then there was the same thing we did last year, where there was somebody in the class that talked about energetic vampires, patients that just sucked his energy out. And he's a young practitioner. And you know, he's just not going to survive that.
Yeah.
And we did the same, how to contain your field. Yeah. There's absolutely no reason your energy field should be out in the driveway trying to heal the lady that's out in the driveway. So bring it in, and we did that exercise.
I love that.
It was so much fun. And Max from Taiwan got a photograph of it that I will send to you. The first photograph is the start of the exercise. And there's this black column coming up towards the ceiling. The second photograph, the black stuff is on the ceiling. The third photograph, there's lights around his chest. And the fourth photograph is just him and me and the room.
Wow.
It was. It's like, Max, is this real? Did you do this? Is this like Photoshop? He said, no, it's just took pictures of it. He said something about an app, but I don't know an app that would pick that up. So anyway, I'll send you the pictures. It was really cool.
Yes. Okay, here comes one of my questions.
Okay, go.
We talk about tearing apart scar tissue a lot. That's one of the most favorite things on the planet you can do with manual therapy and FSM. And that was the whole experience that I had, because I knew what I was touching wasn't possible when somebody was showing me FSM. It was a practitioner that I deeply, deeply respect. And when we did something, and then we ran 13 and 142 and 13 and 77, and within 2 minutes, it was like pudding. It was that moment of, I had to take my hands away, and I had that look that you're just doing right now. Like, that's not possible. It's like, did I have some sort of seizure and 2 hours elapsed, and like somebody just like worked and worked and worked and worked, and then all of a sudden the tissue was warm and pliable and fluffy, pain-free, right? So, and if it was just that easy to just do 13 and 77, 13 and 142, life would get pretty boring pretty fast, because we know it's just not that simple to just put those frequencies on and things turn to
13 and 396, 13 and 60, 23,
and
37.
all the things. But to me, the greatest shift in how I treat and how I look at people and how I look at injuries and how my assessments and everything else has changed is asking, why is it scarred? Don't just simply settle with it's scarred. Yes, you're going to need to tear it apart and you're going to need to get that tissue moving better. But like the real magic happens when you figure out why did it get scarred. And this is kind of where my question goes, because I've been spending a lot more time on the basics, and they're called the basics for a reason. And when I really start thinking about the basics, I have so much more respect for it. It didn't just scar. And if you think of the basics, there was some sort of trauma, and then it was not able to move, which what we call is paralysis. And then when that happens, then we have the whole histamine reaction that starts the whole inflammatory cascade and keeps the cycle of unrest happening in the tissue. And it's called the basics, and we talk about it, but we need to like pay homage to the basics a little bit more. And I don't know if it's more time or what.
You can do a drive-by.
Right.
Just try. So had a patient this week who had liposarcoma, where the kidney fat pad on the right side became cancerous. And they found it by mistake. She had a pulmonary embolus. They did a CT and found this literal, like the tumor was the size of a small watermelon, like 5 pounds, 5.5 pounds. Removed her right kidney. And I treated her before the surgery. And then surgery was 3 months ago. And this time this is the second time I've treated her because they did radiation. And this is the second time I've treated her post-operatively. And it's the first time she mentioned that she had low back pain. And I went, oh, did they leave, when they took your kidney out, did they leave the ureter? Yeah. Oh, okay, that's easy. So scarring in the ureter, scarring in the kidney, but they did radiation to kill this tumor. It's a very rare kind of cancer. So there's a lot of radiation. And so I did scarring in the ureter, just like we do for the psoas. You can't do scarring in the kidney because there's no kidney there. Scarring in the bladder, scarring in the vagus, scarring in the ureter on the left, scarring in the kidney, sclerosis in the fat pad, and then scarring in the small intestine. And then we started talking about the process of how they got to the kidney. So they left the omentum in, but they take the whole small bowel and just get it out of the way. So I did trauma 294. I didn't do the whole sequence. I just did trauma in the small intestine. And she just went, oh, that feels really warm. Trauma in the ureter, trauma in the kidney that's remaining. And so you're absolutely right. It really makes a huge difference.
Yeah, it's just the paralysis frequency always kind of tripped me up because it's just like the word hemorrhage, right? It's not true paralysis and it's not true hemorrhage. But when you think of hemorrhage as bleeding and you think of paralysis just in the real basic term of something's not moving, right?
Well, it's Control-Alt-Delete. It's reboot somehow.
But it's not reboot in the way where it's coming back online and it's coming back better than ever. It's just,
hello.
It's this weird, I think you refer to that like the shock of the injury, right? A lot of the times like with that sequence. And that's to me what it feels like. It's like all systems just shut down for a second.
It's kind of like when your computer locks up.
Yeah.
Nothing wrong with the computer. It just dropped a line of code that tells it what to do next.
Right.
And obviously her left kidney still works. Her small intestine still works.
Yeah.
But according to Harry, that doesn't work quite right.
Right.
It just dropped the line of code that tells it how to be the way it was before.
Yeah. That is a great way of explaining it. It's so funny because after all these years, and yes, I would do drive-bys on it just because, but I was just spending more time with it. And like I said, sometimes you're just looking at the laminate and it just pops out at you. And I have the whole like buddy thing happening too, which is great when I'm trying to find something. But there's something just really like, I don't know, poetic about just going through the laminate and being like, what is this? Because we do learn to just think not only outside the box, but just in different directions. So to pull it all back, I think if we can just simplify it by, yes, what is happening and where is it occurring, but how did it get like this? Like that will really guide you into those pockets to ask the better questions, and that's where that history is so helpful.
Well, and the thing to remember is that inflammation causes scar tissue.
Yeah.
And bleeding causes scar tissue. So during her 8-hour surgery, there was one person whose job was to irrigate her abdomen and suck up anything that bled.
Right.
There's no way to get it all.
Right.
So when I ran scarring in the connective tissue, that did some stuff, relaxed some things, especially the central scar that goes from her sternum down to her pubic bone, because it's the basement membrane in the skin, and that basement membrane is connective tissue. But it didn't take care of her belly. Duh, the peritoneum is fascia.
Yeah.
So we did scarring in the fascia. And there was an osteopath who was visiting that was checking her cranial rhythm as only a cranial osteopath can.
Yeah.
And when I did scarring in the fascia or the peritoneum, he said, oh, everything just centralized. The only thing that's left is that central scar. Oh, there it is. So we treated the scar some more, and it was just really fun. And scarring in the vagus.
Yes.
If you think of, right, and trauma in the vagus, it was just really fun to work on. It's unusual to have a patient come before surgery.
Yeah.
And say, I want everything to be as healthy as it can be after 32 sessions of radiation.
Right.
Okay, I can do that.
I think that's why I love working with athletes, and we're talking about the whole ACL kind of prehab that they're doing. They're really kind of postponing the surgery until we can get full knee extension and we have strength in the hamstrings and we have a nice healthy quadricep if they're going to do a patellar tendon graft. And I think a lot of it too, I would think, is being injured, going through surgery, having a chronic illness, we lose so much control and we lose so much of ourselves. So to have something that we can do before surgery, whether it's reconstructive ACL or it's something like what you're talking about, visceral, to do something that's going to give your body the best chances of having a successful surgery, having a successful recovery, that's got to do so much as far as like empowerment and for just your overall sense of, like I said, just getting control back. And I know with the athletes that I work with, having their own custom care is that sense of control. I know 3 times a week, I'm going to go out and essentially get into a car accident. That is the biomechanical equivalent of what some of these athletes go through. But to know
this
that,
is what it goes to do for a job.
right,
Yeah.
that they love.
Yeah,
It's such a neurological and psychological dichotomy of just going into this arena, knowing what's going to happen, and hope that you're going to sustain it, recover from it, and then with this athletic community, go back and do it all over again next week. So
dopamine and endorphins.
right.
I mean, what could be more fun?
But again, just kind of going back to that sense of control. And I remember at an advanced years ago, meeting somebody and then saying like, well, what kind of patients do you treat? And it was, oh, I treat a lot of fibromyalgia and chronic pain. And then someone asked, well, what do you see? I'm like, oh, I see a lot of athletes, a lot of professional Olympic athletes. And they're like, whoa, that's gotta be so hard. And I'm like, I think what you are doing is so hard. But, we're coming at it from both the same kind of profound respect of what these patients are going through psychologically on a daily basis. Yes, the athletes are structurally very sound. Their tissue is very healthy, but you are under so much pressure. We have a frequency for that to perform and recover and rehab in a time frame that is not realistic.
And because you're treating them during the season, you're always treating new injuries and subacute injuries. And I don't know how you ever get around to the chronic stuff until the off season. And depending on the sport, sometimes that's 2 months to get them in. And it's like, now can we take away the scar tissue in your armpit and your groin and your whatever?
Yes.
Yeah.
And it's always, yes, you're right. You're always kind of layering. There's always an acute inflammatory response that's happening. And that's how our recovery and DOMS protocols work so well, as we're kind of mitigating that inflammatory response that they go through. But you want an inflammatory response. Like, not all inflammation is bad. We need macrophages to go. They are the cleanup crew. We need some inflammation everywhere to go clean up the debris. And the key word is to vacate from the area as fast as possible. And that's why FSM is the magic secret sauce.
And there's another piece of it. I had a wound care specialist at UCSF 20 years ago, 24 years ago. We were talking about wound healing and what FSM does in wound healing, what we observed. And would he be interested in helping me document this? And I said, well, we increase ATP production with the current by 500%. We stop the bleeding because they don't bruise. And the wounds heal in half the time. And he said, that's not possible. I said, yeah. He said, no, really. The process of recovery in the scientific, like normal recovery, ATP goes down because there's disruption. ATP is conducted through the fascia, right? You tear something, well, the wires are busted. So the ATP goes down, inflammation goes up. With the reduction in ATP, the increase in inflammation, and the bleeding causes scar tissue. And that's how the wounds heal. Right. And we increase ATP by 500%. We use frequencies that stop the bleeding so they don't bruise. We reduce inflammation. And I hadn't even got to torn and broken at that point.
Right.
And the wounds heal in half the time. And all he could say is, that's not possible. Okay. So this lady with an 8-year-old SI joint sprain, we ran torn and broken in the connective tissue and torn and broken in the ligaments to precision cares for 60 minutes. The injury to the SI joint was 8 years old. It was kind of sort of stable, but every now and then it would just sort of slide out of place if she moved wrong. She got up off the table and it was stable for the whole week. So how did 124 do that when the injury was 8 years old and it had kind of sort of healed, but not exactly?
Right.
This is the part of what we do that just fascinates me constantly.
Do you know what I think? I had this conversation with a PT and a surgeon last week, and we're talking about chronic instability in shoulders. Shoulders have sort of been the thing that, like, all the shoulders seem to jump on a bus and find me.
True.
And I love them and I'm happy they come, but they sort of kind of drive me crazy at the same time. So whether it's frozen shoulder or chronic instability, it's a very tricky balance of when you have scarring that's holding together a shoulder and then you undo it and you're creating more instability, or you have a shoulder that's just kind of not fully as tight as it needs to be and there's this shifting that's happening. And I've found that 124 on A, 783 on B, torn and broken in the periosteum is what's helping. If you think about instability in a shoulder that's not in the optimal position, right? So there's this constant maybe grinding on one area of the humeral head on the fossa, whether it's superior, inferior, anterior, posterior. And when that's always happening, it's kind of like, like the analogy I use is there's a boat tied to a dock and there's a rope and it's just kind of over and it's just getting frayed. I mean, that happens with the periosteum. So that deep bone achy pain that people feel, I mean, yes, it could be coming from a tendon or the capsule, but when they're saying deep and achy and I wake up with it, or it gets worse after exercise when I'm trying to strengthen it. Like, you're not going to be able to strengthen something optimally if there's pain while you do the exercise. Like, the recruitment is just never going to happen.
And it's not going to happen right. And when shoulder movement patterning is wrong, every analogy of the boat and the fraying, because everything is dependent on proper movement in the shoulder.
Yes. I'm just going to add, and then the shoulder spills into the ribs, into the neck. So the shoulder is never the shoulder. Sorry. So
No.
People that come in and they're like, I need to take a look at your shoulder, and they do this. And I'm like, I'm going to need to see all of it. Ribs, clavicle. They're like, wow. I'm like, yeah.
So I had a patient this week that he was in with his wife, who was the patient, and he mentioned, it's like, I have to make an appointment with you to see my shoulder. And it's like, well, we got 20 minutes left. What's wrong with it? He said, well, I was putting together a swing set 20 years ago, and I had the rings, and as I swung, the ring on the left let go, and I had all my weight on the right, and I just strained my shoulder. So I've had it proload all to pieces. So he proload here and he proload there and PRP'd here, and it's like, yikes. So it just hurts all the time. Okay. So I started on the subscap, and he said, why are your fingers in my armpit? And I said, because we can do anything we want to the rest of your shoulder and nothing's going to work until your subscap allows external rotation and abduction. Okay. He was an osteopath. So got a subscap to behave itself, 40 and 3. He said, yeah, that's the place. I went, yeah, attached to the eyebrows. Got the subscap to behave itself. And then there added a slide to the core and the practicum. So we did torn and broken because they had proloed the biceps tendon. So scarring in the biceps, and then torn and broken in the biceps. And he said, oh, that feels better.
Of course it does.
Yeah, of course it does. And then his shoulder, the injured one, was forward. So I went down and found the pec minor.
Mm.
And he said, oh, that didn't get injured. And I went, is that tender? Oh, ow, okay. So scarring in the nerve, scarring in the arteries, scarring in the vein, scarring in the fascia, and then torn and broken in the connective tissue. So you get rid of the scar tissue first so it can fall back. But because the pec minor has been holding the whole shoulder together, all 3 inches of it, and
you're like
a centimeter and a half of connective tissue holding onto the coracoid. I do torn and broken in the connective tissue, and all of a sudden his shoulder just drops back. And then as I started to abduct it, didn't move right. And remembering what happened in Dublin with that patient, is there any way to do this on rings with your full body weight and not traumatize the labrum?
Yeah, no.
Can't. So I did torn and broken in 214.
Yeah.
And all of the muscles in his shoulder just went smush, and the humeral head slid back into the groove. And I did trauma in the labrum, and it said, thank you very much. And then he said, yeah, the only other sore place is right here. And I said, well, what you're pointing to is the deltoid attachment and the subdeltoid bursa. So I did torn and broken in the connective tissue and the attachment, and then just inflammation in the bursa all over the shoulder. And he said, pain's gone. My shoulder has hurt all the time for the last 20 years. Yeah. And I looked at the clock and it was 22 minutes.
Wow.
It's like, yeah.
Yeah, but I mean, that's just walking through the history, knowing your anatomy, knowing biomechanics, and putting it together.
Hi, dog.
They're both running around here somewhere. We have a couple questions we should probably get to. Our time is just... So grooming cats, is there a way to use FSM to either calm or decrease sensations for cats and dogs and possibly other animals? Cats and dogs love FSM. I mean, I don't know about cats because I don't have any, but I see pictures of cats. And whenever I bring my dogs to the clinic, it's so funny. My German Shepherd has to sit in the corner and learn to not murder and kill everybody that walks in the door. But very slowly she'll like army crawl across until she's as close as humanly possible to the devices because they love it. I don't know how grooming cats. Could you treat yourself and then treat the animals? Like we treat...
Put the magnetic converter on them, like if you're grooming your own creatures. The basics again, 94 and 200, 970 and 200, 40 and 562. If you have one that is just hypersensitive, skin is really sensitive for some reason.
Yeah.
Treating a person for being ticklish.
Right.
A patient that's so ticklish, you go to work on their psoas and they just break into gales of laughter and curl up in a ball. And it's like, oh, I can fix that. I've been ticklish my whole life. I know. And you just do 40 and 92. And you wait. It takes about 2 minutes. It's really, really fast. And then you put your hands on and the patient goes, what did you do? And it's, oh, just turn down your sensory cortex. Okay.
No big deal.
So it depends on whether their anxiety is emotional, afraid of being touched. It's like, it's not normal. So with this patient, I was working on his shoulder. He kept contracting it. And I said, I promise I won't drop it. And he said, I'm just so used to protecting it. I don't know. It is not normal to let someone do this to you. Oh, then he could relax. It's
Right.
like, it is perfectly okay to not be okay with this.
Right.
Trust frequency, 94 and 200, 970 and 200, emotional tension, nervous tension, 40 and 562, turn down the sympathetics, 40 and 92, make the sensory cortex just take a nap. If the cat or dog or horse has been abused before by somebody who was not nice, you can do 40 and 89. And that was interesting. For a new groomer, yeah, I would do that. Debbie, how do we do the energy exercise? Wow. I come to the come to the master class sometime, because we did it last year too. It just always comes up. Basically, everybody has an energy field, and I have to say, I didn't invent this. My first year in practice, 2 years, I was so exhausted all the time that George and our clairvoyant naturopathic student, we invited one of the members of the healing group that we knew for sure was not an energy vampire, because some of your patients that are desperate and frightened and in pain, they're like somebody who's drowning that reaches out to grab a life ring. They'll grab anything that floats, and sometimes that's your solar plexus, right? They just grab your energy. And so the clairvoyant naturopathic student could see that every time I just focused on the patient's back and started working on her low back, the blue field that should be around my arms turned brown. So it wasn't that she was taking the energy, I was using my own energy to work on her. So it took them an hour and a half to teach me how to work on somebody and not use my own energy. So what I do during this exercise is get people to bring their field in. So your energy field should be, we do this thing when we clap and rub and you feel this ball of energy. And then once you know what it feels like here, you reach over and you feel where your energy is next to your arm. Then you feel your neighbor's field. And the show and tell part is because of what I did with George and the healing group and all the rest of that. I can sort of, I don't see, I just sort of know where it is. And I reach over to find it and it's just not there. And you look out and it's at the back of the room trying to heal the person that's sitting in the corner. It's like, your field doesn't belong out there. Your field belongs to you. Your energy belongs to you. And nobody but you gets to be inside of it. Mm. So get them to feel where their field is, bring it in until I can feel the edge of it, then have them bring it in closer to their body, then have them breathe in through the top of their head. I have them go to the sun, bring in little gold sparkles. The sun's energy is pretty neutral. And fill in their field and push my hand out, because we can feel it. Push my hand out. Come on, you can do it. Okay. Now, bring my hand in. So they learn how to feel where the edge of their field is, and then bring in the sun's energy. And if there's anything inside your field that isn't you, it'll look different to you. I don't know what it's going to look like to you, but it'll look different. And you take the sun's energy, just visualize those fiery balls on the sun, and you turn whatever isn't you to ash, and it just gets to go away. So we think that's what that thing was.
Right.
Doing that with a core seminar is not possible.
Yeah.
Doing it in the advanced, there's too many people.
Yeah.
So the masterclass is kind of the only place to do it, where there's just 20 people. And it comes, so we've done 2 masterclasses and it's happened both times. So I'm assuming it's going to be a
thing.
Yeah, but it just happens organically. I don't plan on it. There's always somebody that has the question, because we all run into it.
Yeah. And the masterclass, I think also, not only just size, it's just mileage. People have been using FSM for a while, and they've had just that time to encounter those energetic vampires, as you call them, right?
Yeah, or the patient may not snack on it. You may just give it away because you're such a nice guy.
Right, right.
So, recent neurofeedback treatment for ADHD, anxiety, depression, neurofeedback, developmental trauma, brain location, brain location for resolving chronic pain maintained by the amygdala. It's, yes, thalamic pain. So it's 40 and 89. And 89 in our world includes the thalamus, the hippocampus, and the amygdala. Neurofeedback has mostly permanent results. Yeah, but it's expensive and it takes freaking forever. FSM could be a great adjunct to see if, Dana, FSM would be a great adjunct to change the neurofeedback from 10 to 20-second sessions to maybe 4. It's kind of like hyperbarics. 20 neurofeedback sessions is what, $3,000-$4,000? And same thing with hyperbarics. Oh, you'll be fine in 40 sessions at $200 a piece. Okay, fine. So concussion in vagus, and increase the amount of time on 40 and 89. We did have a patient that, because 40 and 89 felt so good, she ran it for 6 hours a day for 3 days. And at the end of the 3rd day, she was a total mess. And so I asked my friend, Dr. Wood, what happened? He said, well, the thalamus plays a role as a buffer. Not only, anyway, so he's going to talk about that at the advanced, I think. So needless to say, she recovered by running 81 and 10 and little teeny doses. So that was pretty fun. You want to take the next one?
Bumpy shin bones.
Yeah.
Possibly not actually the bone, but maybe FSM could address some of the other tissue attached to the bone to resolve the bumpy texture. So, yes, you take it, and then you're like, periosteum. So whenever we have bumpy, especially on the knees, so I'm going to just throw out the most obvious case I can think of, Osgood Schlatters, because I've had 40 teenagers I got to treat this for years and years and years as they grew and grew and grew. With Osgood Schlatters, yes, it's the bone and the pain is the periosteum, but it's because of the connective tissue that's pulling from it. So again, like the bone just doesn't get thickened or bumpy for no reason. We refer to this as Wolff's Law, right? There's tension, and there's tension on connective tissue, muscle, connective tissue, tendon, bone, and your periosteum is that first line of attachment to the connective tissue. So 13 on A and going through the connective tissue, fascia, tendon, connective tissue, periosteum,
One,
Yes.
12 slots calcium.
Yeah. Yeah. So 13, 191. We talk about 13 loves to be mobilized. So with the knee, it's just really easy, even if you're sending a patient home with a device, to get them to just do some flexion and extension. And that just kind of helps pull the connective tissue through. It helps mobilize the adhesions, helps with the scarring. I even mobilize with 191, to be honest. I think movement is always a nice, I think FSM just creates movement. Like it just, we want to move.
So you mobilize when you're doing 91 calcium?
Yes.
Yeah, that makes sense.
Anything that's hard, especially if it's in the connective tissue, I want to pull it through. So whether it's with manual therapy or active or passive movement, and it's like sneaking in a retest as you're doing it. Is this working? Is this feeling better?
And it's fun as you feel the periosteum when you're doing 91, the periosteum scarring, and the little lumps just disappear.
Yeah.
How'd you do that?
Yeah.
Yeah. It's magic.
And then I'd also say, if it is from something like jumper's knee or Osgood-Slaughter's or whatever you want to call it, following up with vitality to the area is very, very, very helpful. 49 in said tissues as well.
And thank you very much. Since you've been the vitality fairy, I've been using vitality more. Yes.
It makes me happy. I just love 40.
Yeah.
I'm like, oh, it's time for 49 now. And for some patients, I've been actually using it before the treatment, before running scarring. And again, I just think of, Dr. Roger Billica talking about such complex cases. And then he says something like so simple for like the peasants in the back. And he's like, well, sometimes you just got to put in the good before you take out the bad. I'm like,
oh, I remember him saying, take out the bad stuff, put in the good stuff.
But then sometimes he was saying, sometimes you got to put in the good before you take out the bad. And he was talking about like very complex, like supplements for a very sick person, but we hear things for a reason. So when I hear that, and I don't prescribe supplements and I don't see the patients that he does, but sometimes there's tissue that is just so damaged or dehydrated or stuck that yes, you need to take out the scarring, but maybe you need to increase the secretions or the vitality to the fascia first. Maybe you need to just fluff it up before you can take out the bad.
Think of putting in the good stuff is why we run concussion in Vegas,
Sure.
Or why Harry ran concussion. That's putting in the good stuff.
Yes.
Just getting the nervous system to be healthier.
Yes. And receptive and open to all the stuff that you're going to do.
Plus that. And then Annie. Hi, Annie.
Hi, Annie.
I like real-time labs.
So the question for the people listening on the podcast who can't read the prompter says, can you please name the labs that you prefer in the USA for testing mold and Lyme?
Mold, I use real-time labs mostly because there's another company, Great Plains, and real-time, and I set in match samples on a patient where I knew his symptoms and actually knew what kind of mold he was exposed to. Did a urine mold test with Great Plains, urine mold test with real-time, sent them both in on the same day. Great Plains said he was fine, and real-time said exactly the molds we knew he was exposed to in the quantities we knew, and it matched his symptoms. I don't treat Lyme, so I don't know about Lyme. And I know there's a thing about bands, like how many bands. So there's kind of a dosage thing with Lyme where you can have a little bit and maybe that's not causing your symptoms because you have one band. Maybe if you tested 100 people all with no symptoms, 100 of them would have one band that's positive for one of the Lyme critters. 4 bands or symptomatic, but I can't remember what the name of the test is. So I would leave that to Roger Bellica or Neil Nathan. Somebody. Hi, Derek. How's Grandma?
I think those are all of our questions. And we have a minute to spare. And it's so funny because I have my daughter's very favorite mug. So I always have like my FSM mug, but she went to college and it says, "What would Beaker do?" So we love the Muppets. And Beaker is one of our favorite scientists. So I'm using my inspiration because she would always kind of have this face when she was like upset. And so now she's off across the country doing great things and learning all the things. So I'm using her mug today as my homage to my sciencey daughter.
Oh, that's so cool.
Who was very strict about what she was going to take with her to college. And one of my custom cares ended up in her bag. And she's like, "Oh, well, it's here now. So sorry, Mom."
How could we send anybody off to college without a custom care and a magnetic converter?
Especially an athlete. So I was like, just tell me you took one of the old ones.
Programming cable so I can reprogram it if we need to.
And yes, and I'm sure we will. So that is it for today.
Wow. That was fun. Grandma is back to normal. So there was a hurricane in Hawaii after we left.
Oh.
And his wife's mom fell and hurt her knee. So they treated her and she's back to normal. Yay.
Oh, that's good to hear. I'm so glad.
Yes, we're gone next week.
Yes.
To Poland.
Yes.
And the week after that, we might still be in Poland.
Okay.
And then the week after that, we're in Rome. And we get back on the 25th of September at 7:00 at night. Yeah, so we're going to miss the 25th.
I will try to get some stuff rolling for some of these dates.
One of these days, you can do it all by yourself. You don't have to have a guest. You can do it. What do you think, guys? She can do it, right?
Yeah.
She's done a couple.
Yeah.
I need to have slides. I feel like if I do a little webinar on something, that just kind of helps as opposed to, so maybe I will put together some of my all-time favorites. How about that? And I have an idea for a very good guest. I just don't want to put it out there just yet. So,
yes. Leaf says, the Kim Show.
Yay. Well, we'll do my best while you are out doing good things. I'm glad we could at least connect today.
Me too.
All right, everybody. Well, if you have questions for the Kim Show, you send those over to me so I can start gathering some materials.
Okay. Musnick asked us to do tick-borne complete with vibrant wellness for Lyme.
Oh.
Tick-borne complete 2.0. Vibrant Wellness is the company.
Thanks, Kathy.
Thank you, Catherine. And thank you, David Musnick.
Yes. Great. And thank you. So we'll
see you in a month. Oh, bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.